Hello and greetings from the GREC. What is the GREC? Well, the ACRO GREC is the Government Relations and Economics Committee. This is a committee that works very hard, often behind the scenes, for the benefit of all members. And so it has some very important functions. One of the things that we've been talking about a lot lately is the whole matter of the new code set, and the GREC has been very, very involved in that. So I'm Chris Jahraus. I'm a radiation oncologist in suburban Birmingham, Alabama, and I'm the RUC advisor to the AMA and part of the team that has worked on developing these codes. We're joined tonight by Laeton Pang, the chairman of the GREC Committee, and by Jason McKitrick, ACRO's Legislative and Advisory Council. So Jason, tell us sort of what the outline for tonight is.
Thanks, Dr. Jahraus. I think what we had planned on doing is talking a little bit about the history of the new code set, and there's a long history here going back over a decade. Wanted to talk to viewers a little bit about, specifically what the new code set is that's going into effect in 2026, and then finish up with some of the practical implications of the new code set and what folks should be doing to get ready. And I'm happy, Dr. Jahraus, to talk a little bit more about the history of how we got here.
Yeah, yeah. So, Laeton, would you like to say just a word about the GREC and what it does for the benefit of ACRO members more broadly before we launch into this?
Sure. So GREC stands for Government Relations and Economics Committee. And the main function of the GREC is to look at advocacy and health policy, specifically as it relates to CMS policy with regard to the Medicare physician fee schedule, the hospital outpatient prospective payment system, and to provide feedback to policymakers and to CMS on radiation oncology reimbursement, such as where we're not really happy about the radiation oncology alternative payment model. So here's an alternative in the form of the radiation oncology case reimbursement model. So we have those things going on. And then there are also educational pieces like what are we doing in terms of the history of radiation oncology reimbursement? How did all these things come to be to educate members about the basics of radiation oncology reimbursement?
Well, with that as sort of a background, maybe Jason, can you give us a little bit about the history of how we got here? We're not quite at the rocker case model or a case reimbursement system that we'd like to be at, but what do we have for now, and why is there this change all of a sudden?
Yeah, I mean it really has been over a decade that this quote unquote new code set has been underway. We was first launched, I think, back in 2013 for the 2015 fee schedules. And there were some real issues with the code set at the time. CMS had raised concerns, and most importantly, the code set going into place back then would have been, clinicians would have seen pretty significant cuts under the new code set, particularly in the office-based setting. And so, ACRO was really one of the lead organizations in 2015 to get the freeze on the rates for the freestanding setting. And as part of that law, the PAMPA legislation, there was also a report to Congress requirement by the Secretary of HHS on an alternative payment model for radiation therapy. And that was kind of the regime for, as I say, upwards of a decade. Once we got the freeze, we kind of entered into this period of, working with CMMI on a new radiation oncology alternative payment model per the PAMPA legislation. Had lots of conversations with CMMI about that, and really made significant progress over the years with CMMI. But unfortunately, there was, towards the end of those proposed regulations out of CMMI, it got to the point where the cuts were just too steep that CMMI wanted to implement, and the in conjunction with how the geographic areas were included, it was unworkable for the majority of the radiation oncology sector, and so they paused it. And when they paused it, I think there was an interest by policymakers to move forward with the code set that effectively had been on pause since 2015. And that was a sort of epoch that we had been under over the last, couple of years. I'm really happy that that ACRO and ASTRO and other relevant societies work together so well to get a code set
Yeah.
that
Can
made
you
sense.
can you talk
And
just a
yeah,
little bit
please. Yeah.
about how that interaction between Astro and Acro works? And I know, although I don't think everybody realizes necessarily that there are a very limited number of voices involved in designing these codes.
Yeah, I mean, and so there's, you know, sort of two main committees within the AMA that are involved with defining and valuing codes. There's the CPT that does the definition side and the RUC that does the valuation side. And we had great team from Macro and Astro, both on the CPT advisors as well as the RUC advisors, all the way through the process. It's important to get the code set right in terms of how you define it, because that has a big follow-on effect in terms of how those things are valued. And what was interesting too, though, is you do see echoes of a lot of what we've been sort of trying to do through the radiation oncology APM, through what Astra had proposed through Rocker in
Things
terms
like
of.
getting away from the old structure of the codes and things.
Yeah, in terms of particularly on the office-based side, valuation and linking the
Okay,
office rates to the hospital rates.
right.
There are echoes, I think, of the radiation oncology APM, of Rocker, et cetera. And I think as you indicated, the job's not done, but I think there's some stability that has gone into place now, which has been needed for a long, long time.
So, Laeton, you and I are both freestanding centers or have freestanding centers. I think it would be valuable to hear your perspective on how ACRO does its job of representing everybody, including those of us in the freestanding center. What's your take on that with ACRO and specifically with the GREC?
Historically, ACRO was formed because of concerns of freestanding centers that their issues were not being addressed by other organizations. And ACRO continues to focus on issues not only with the freestanding, but with the idea that what happens in the freestanding centers is going to trickle on out to other areas in radiation oncology in the hospitals. And so it's evolved in the sense that now we have people in the hospitals who are very engaged and also involved and very concerned about what happens in the freestanding centers as well as in the hospital centers.
No, I think that's true. And I think that's a pretty good history of how we got here. I mean, there's obviously many, many sort of winding, avenues that have gone over the last 10 years. But Dr. Jahraus, I think it helped folks to, maybe lay out in broad strokes what the new, treatment delivery codes and related codes are, and how those have
Sure.
changed.
Yeah, sure. So we've gotten rid of all of the G codes that those of us under the MPFS are used to, and we've gotten rid of 77014, which was our image guidance code. For the new codes, it's much simpler. It's down to three codes. Those are 77402, 77407, and 77412. And those correspond to simple, intermediate, and complex radiotherapy delivery. These are only the delivery codes. It has no impact on the treatment planning codes. One of the big changes is that image guidance is now incorporated into the treatment delivery code itself. So that is accounted for, at least in terms of the technical part of it, and does not need to be built separately. Now, the reality is that there's still some physician work involved in reviewing image guidance images. And so for that, there is now code 77387, which represents basically the professional only component of image guidance. So there is still that. In terms of what's the new treatment delivery codes are, 77402 is simple. And these are basically things like simple electrons. Let's say that you're treating the back of a hand and you're just using simple electron field, NFOS, some superflab, whatever. That's going to be a 77402. In the rare circumstance where you're using, say, just a single PA spine field, and you're just doing a calculation to Dmax, or if you're doing a parallel opposed field and it's calculation to mid-plane, those sort of 2D treatments, those would fall under 77402. But to be clear, the expectation is that that's only going to account for 3 to 5% of the total book of business within radiation oncology. 77407 is really going to be the workhorse code. That's expected to cover somewhere between 55 and maybe 65, somewhere in that range, percent of the codes, probably closer to the 55 to 60. And that is intermediate. Again, this is 77407. This is anything that requires 3D planning. There, so if you're treating that same spine with, say, a posterior array where we're using an RPO, an LAO, a PA, and an AP, and we're trying to, say, avoid the kidneys and make sure that we have a reasonable renal protection and that sort of thing. That's clearly a three-dimensional conformal radiotherapy plan, and that's going to fall under 77407. Other things that are going to fall under that are going to be any kind of one distinction. There's no longer a distinction in the treatment delivery codes between IMRT and 3D conformal. So those are really just things that are on a spectrum of complexity, as we all know. So let's say that you're treating a prostate. This is something that doesn't move. So the key to 77407 is a three-dimensionally planned treatment that does not involve motion management or some other specific peculiarity, which we'll go over in just a sec. And so, for instance, the vignette that was used for the AMA or from the AMA was a prostate plan. Not really a lot of motion management going on there. Whereas anything in the thorax and the abdomen, other than perhaps the spine, there is that potential for respiratory motion, and that's where we get into motion management. So 77412, the probably most frequent differentiator is going to be anything that requires motion management. So if you're treating the lung, if you're treating the breast, these rise and fall with breathing. If you're treating a pancreas, the diaphragmatic excursion can cause some motion that needs to be corrected for. If you're treating a liver, a stomach, abdominal nodal disease or something like that, these all may be situations where motion management is legitimate and appropriate. And in those cases, you would use motion management. What does that consist of? Just a quick review. That would be things like deep inspiratory breath hold, respiratory gating, 4D cone beam CT, and yes, surface guidance as well in some of those. Those are going to be motion management. There are a couple of other scenarios in which you would use a complex code, and that would be things like multiple isocenters. And so, for instance, in medulloblastoma, you would be treating a craniospinal field. You'd have a separate isocenter for the head and for the spine. Let's say that you're treating 3 different lesions at once. Let's say you're treating brain mets and left shoulder and right humerus or something like that. You've got multiple isocenters going on at the same time, and so there's additional work involved in that, and that defines that. Other scenarios that would raise it to the level of complex would be mixed electron photon plans. So again, let's go back to the hand idea. Let's say you got a really thick hand, and you're doing a high energy beam from one side and an electron from the front, trying to concentrate that energy right in there, but getting it deep enough. That would be a mixed electron photon plan. There may be others where, let's say that you're trying to include the scar and you can't get that adequately in a post-op patient, that would be an example. And then finally, the only other one that I'm thinking of is total skin electrons. That would also constitute a complex treatment. And there may be some other peculiarities which will be meted out in the coding guides that are coming out. But those are the
So, Chris,
basics.
with regard to prostate, because you brought up prostate, so adaptive radiotherapy, where does that fall? Because it's not active motion management.
Right. So this doesn't address the question of adaptive radiotherapy. And the reality is that we don't have good adaptive radiotherapy codes. And that is something that is absolutely positively on the agenda of the RUC and CPT committees. And both ASTRO and ACRO are well aware of that and, believe that that needs to be addressed and uh, are already and will more formally be working on that to rectify that so that there are unique adaptive codes. But for clarity, none of this addresses adaptation. These are only treatment delivery codes.
But these are, greatly simplifying the current
Oh, yeah.
state, right? I mean,
Yeah,
we've
we
gone
went from
yeah,
17 or something codes down to 3 plus the IGRT add-on for the
right.
professional
And
component.
they'll be the same in both sites of service, right?
Yeah, exactly. So
Yeah,
whereas before you were using 77385 and 77386 in
right.
hospital-based, for IMRT, simple and complex, although they paid at the same rate. Now and in the freestanding center, you would have used G6015. Now all of us are on the same plane. We're all using the same codes. And as you mentioned before, something really encouraging is that there's some indication that we're getting some of our cost bases figured based on the same things that hospitals are using. And hopefully that means that we'll see greater stability in the future.
And Dr. Pang, so this all gets underway in just a little over a month, right? It starts in January 1.
So yeah, you want to get your centers ready for this change. You need to make sure that your EMR billing and coding systems have the updated code sets to receive those new codes. Educate the staff on these code changes, the ones that are involved in the billing and coding.
What do you think about working with insurance companies and stuff? We were chatting a little earlier about that. How is your center planning to approach that?
Yeah, so we're going to have these conversations with the state Medicaid and private insurance companies about whether they're ready for the new codes. Do we need to continue to use the old code sets during a transition period? What about prior authorization? Those companies that require prior authorization for the treatment, because these new codes, are they going to require another prior authorization for these patients
So
when January 1 rolls around?
So do you think that best practice would be for a practice to have each insurer that requires prior authorization, so like not Medicare, but all of the others or a majority of the others, should we be calling them and saying, "Hey, what do I do? Do I need to do something different or what, how are you guys going to approach that?"
Yeah, we have our team is ready to tackle that. We're looking at each patient's insurance plan. Uh, you have to also remember some of them have expiration dates coming up on
Right.
December 31st. They may need to have
Oh
your
yeah, the
insurance card in your system.
yeah, the January surprise of, oh,
Yeah,
we've got a different company now.
right. Check your insurance contracts for applicable terms. All these things have to be done, and they probably should be done anyway. The hard thing is it comes up around the holidays, but you know
Yeah.
what? Yeah.
Yep. And unfortunately, we had a shutdown that didn't that made it so that we just got some of this hospital information over the last few days. But we do for both settings, physician fee schedule and hospital outpatient, we do have the new rates, so everything should be ready to go.
Well, this is I think useful information that everybody needs to know. Laeton, I think that your concept of best practices with having that review, going over each patient that's on beam, I think that's something that I'm definitely going to implement in my practice. Jason, what about you? Is there not that you have to bill with these codes, thankfully for you, but what do you think is on the horizon in terms of legislation?
Yeah, I mean, I think that's a good way to probably close this out, Dr. Jahraus. We do, as I say, we've got some, some clarity now. The new code set's going to go into place. We got the rates now in place. There's some stability, I think, on these treatment delivery codes. I think it's a good sort of nuance to mention that not all RAD-on codes are going to be linked to OPPS. It's those treatment delivery codes by and large that are, but that's helps
That's
sort
our
of
biggest thing.
helps stabilize. And now we go into question of whether or not there's going to be another Medicare bill in Q1. The reason that the government shut down last month remains, as it relates to these enhanced premium tax credits. And there was an extenders bill that will keep the government open through January. And I think the White House just sent out a proposal in terms of their sort of take on how those premium tax credits should be addressed. That's going to be a lively debate, I guess, is an understatement. Hopefully, we will not go through all this again in January with a shutdown. Hopefully, we will get
Read the
past that.
tea leaves. You think it's 50-50 or what?
I mean, I think in terms of a shutdown,
Yeah.
I think it's, yeah, 50-50 that we could do all this again. But I think ultimately, as happened last time, they'll get through it, they'll figure it out. But I think even more relevant to us is as they're doing all those things on the premium tax credit, there's also this ongoing debate we know to potentially do a bipartisan Medicare bill. There's also been talk about from the White House that if they can't get a bipartisan agreement on Medicare, that they would do something through reconciliation again. So, the next 12 months are going to be, as interesting as the last 12 months have been. But I think it's important for everybody, particularly folks watching this that are ACRO members, that they continue to reach out to their member of Congress and ask for radiation oncology payment reform to give us, permanent stability as far as we can. And we have a Rocker grassroots page set up for you to reach out to your member of Congress and support that. So, yeah.
Well, Laeton, it sounds like the committee that you chair is going to be a pretty busy one this next year. We'll give you the last word.
Thank you, Chris. It's an exciting time, so to speak. And by the way, I co-chair it, not chair it completely.
We'll give Bill Small
with
credit
Dr.
too.
Bill Small. And there's lots of room for involvement. We have 6 different subcommittees. Advocacy and health policy is just one of those committees. There's coding and reimbursement,
I've
which
heard of that one.
includes CPT and RUC advisors, payer relations, which deals with local Medicare contractors and private payers, clinical pathways, which you chair, and publications on that, and educational enhancement. How did we get here? What are basic things that we need to know about billing and coding? And then something I'm thinking about for the future is staffing workforce recruitment. How do we address that as an organization? So there's lots of ways to become involved. If you're interested in becoming involved, please contact us.
Well, with that, I think we bid everybody greetings from the GREC and good luck with the new codes.